So my name is Chandani. I'm a psychiatrist at the Parental and Pregnancy Service, which is a part of the CAD service in Auckland. And my topic today is really substance use in pregnancy. It's really hard to know how many women who are pregnant are using substances, and a lot really depends on how one measures that and what setting one measures that in. Some of the studies in different parts of the world have shown that in the UK, about a third of individuals who are using substances are women, and more than 90% are in the childbearing age. European studies have found 6.5% to 11% range of women using substances and later becoming pregnant. In the Australian studies, drug-taking behavior was measured before pregnancy and after the knowledge of pregnancy. And for most substances, though the use went down, it didn't go down to zero. So people were still using substances in pregnancy. Within Auckland, we don't really have good data on how many women in pregnancy use substances. The service where I work, we will probably be seeing about 100 to 120 clients at a time pre-COVID. It has gone down since then. So I think it's really important to recognize that for most women, substance use does not start in pregnancy. The women who are using substances in a problematic manner who then become pregnant. So we need to look at women and substance use, not just pregnancy and substance use. And the reason why it's important to look at women's substance use is because we know internationally and including in New Zealand, the gender gap of substance use is narrowing. While traditionally it was found that men were more likely to be using compared to women, that ratio is now approaching 1:1. Women also have what's called a telescoping course. So the interval between first use and problematic use and dependent use is shorter for women compared to men. Women are more likely to have comorbidities, psychiatric issues, as well as physical health and social issues, and they're more likely to have barriers to accessing treatment. Being traditionally in a caregiver role, women's substance use is more likely to have an impact on their children, either because of the pregnancy and also because of their role as the primary caregiver after the child is born. And we know that the first 3 years is a crucial period in child's development. So the impact of women's substance use can be quite long-lasting into the next generation's well-being. The common substances that we see within New Zealand in women using in pregnancy is alcohol, cannabis, methamphetamine, opiates, benzos, and a lot of other substances in minor amounts. So this is looking at the data for the service in which I work in a few years back. And we found that, again, alcohol, meth, and cannabis were the three more common substances being abused. The majority of the people were using more than one substance as well. Alcohol, I think it was mentioned earlier how New Zealand has a very high, I think in the elderly, the use of alcohol is quite high compared to other countries. We find that 50% of pregnancies in New Zealand are exposed to alcohol. 1 in 5 women continue to report drinking alcohol after knowledge of pregnancy, and 13% will continue into the second trimester as well. And 10% of the pregnancies are exposed to really high risky level use. I think people are familiar with the fetal alcohol spectrum disorders, and that is a very well-known complication of exposure to alcohol in pregnancy. Within New Zealand, that has a very high economic impact, millions of dollars, and it is the leading preventable cause of non-genetic intellectual disability. It is more common than all the other conditions put together, like Down syndrome, cystic fibrosis, and a few others. The risk of sudden infant death syndrome is 6 to 8 times higher with in utero alcohol exposure. And when we compare that to smoking, which is 3 times higher, it's a bigger problem. Coexisting issues are the norm, and that includes not just mental health issues, but also social issues and physical health problems. Some of the common mental health comorbidities are mood disorders, anxiety disorders, psychotic disorders, attention deficit, hyperactivity disorders, emotional dysregulation, which is not a diagnosis, but it's a presentation. Trauma is very common. 3/4 of moms presenting with substance use disorder have a diagnosable mental health disorder. And if we look at it from the other side, pregnant women presenting with mental health in the mental health issues service, 40% will have substance use as a comorbidity. In our service, more than half were using more than one substance, and actually this is 3 or more substances because there was hardly anybody using only one substance. So 54% were using either 3 or more substances in pregnancy, and we had a very high presence of mental health conditions. 82% of our women had mental health problems. What I haven't put here is that only 14% were actually engaged in any treatment, either in primary care or secondary care for these mental health issues. Social complexities is something which I think as a health service we have often neglected, mainly because we haven't been trained in how do we address this, how do we even assess this. Within our service, these are some of the complexities in people's social situations that we find does impact both their accessing treatment but also remaining engaged in treatment and actually having good outcomes. So more than 3 children, obvious issues around how do you get to appointments, how do you have transport, childcare, food, housing, transport, communications. So just having a cell phone to make appointments, to seek help when there is either a medical event or even other crises at home. A very large number of people did not have any means to either transport themselves or to communicate when they need help. 68% in our sample had screened positive for family violence currently. Oranga Tamariki involvement was then 3/4, and corrections and the justice system was involved for about 1/3. So I think it sort of highlights the fact that it's not just substance use per se when we see women that we need to be dealing with, but also some of these other issues that they're facing and which affects their ability to actually access and engage with some of the recommendations that as health professionals we are providing. Physical health issues are also very common. Again, for our sample, and this is looking at data of people who had a diagnosed condition. So there will be many who will not even go to a GP for cost or ability to get there. So this is really data of those who had actually done that. So about 28% had diagnosed physical health problems. Some of the common ones were hepatitis, various infections, gestational diabetes, hypertension, asthma, arthritis, and some skin conditions that were reported. So our service is the Pregnancy and Parental Service. We are a regional service across the Auckland metro area. We are based in Point Chevalier at Pittman House, but we are actually a mobile service, and we provide care to women who are pregnant or have children up to the age of 3 years. We are voluntary, so informed consent is required from the client, and we will take referrals from anyone, including self-referrals, other health services, GP, maternity care providers, family members, other parts of CADS. And the main criteria is people should have a substance use problem. Sometimes we get referrals for people who have everything except that. So a lot of social issues, and maybe 5 years ago they used cannabis actually. So it needs to be a current substance use issue, and individuals who are having difficulty accessing healthcare and social services and have complex vulnerabilities and needs. So sometimes families and women are having a substance use problem, but are well resourced to go to the local CADS unit or go to their GP, don't have the other complexities, they're well engaged with maternity care. We will then expect them to go to other parts of the health system to get their needs met. So we really look after the individuals who are falling through the cracks and having all those social issues which is getting in the way of them seeking help. What do? We provide AOD assessment, information and support to these families and moms. We assist women to access all the different areas and services that they need, and that's really varied. We will coordinate that, we will attend appointments with them, we will advocate for them, we will pester services. Like I said, we are a mobile team. We have a multidisciplinary team of different professionals, predominantly social workers, but also AOD clinicians, a few midwives. We have peer support specialists, half a psychiatrist, and a couple of psychologists. I think in my whole time that I've been there, I've seen 2 people in the office, and that's because they've wanted to come in. Usually we will go out and see them wherever they are or wherever they want to be seen. So the idea is really to overcome some of these structural barriers, and the main aim of the PPS services, which was set up by the Ministry of Health, was to improve children's outcome and well-being. So we also provide consultation and training to community agencies. So how to refer to us? You can just email us on that email. You can phone our duty person on the stated number, or you can just call CADS and ask to be put through to us. We are a day service, and we don't work after hours or weekends. So just keep that in mind. So we're not a crisis service, and we will get back to you if you leave a message. So in summary, substance use in pregnancy does have long-term adverse impact on children. Substance use in pregnancy starts before pregnancy, and we need to look at women's use of substances to actually address what's happening in pregnancy. Alcohol remains the commonest exposure, and the adverse effects of that are well known. Coexisting complexities are the norm, and they need to be addressed and recognized for us to actually enable recovery for these women and the families and their children. So addressing the substance use in pregnancy does involve, I think, even in the general practice, just education, screening, providing information, and I harp on this a lot, contraception for men and women, because that is really, a lot of times people don't talk about it, or at least in, I think, specialist services, we feel, oh, that's not our job, that's the GP who's going to do that, or the midwife who's going to do that. But I think it's everybody's job to talk about contraception, and linking in with appropriate supports, and really looking at working in a multi-agency manner. It's not just about mental health or addiction services or primary care, it's also about social services, housing, and the policies that are in place to enable these families to thrive, really. So removing barriers, which are both in terms of stigma, the social, and the systemic barriers that are in place because of the way services are set up. So that's all I wanted to say, really. I guess this is one of the guiding sort of values for our service. that Kote Wahine, Te Kai Tiaki, O Te Whare Tangata, women are the guardians of the House of Humanity. They're the guardians of the past, present, and future generations. I'd like to end on that. Thank you.